Thank you.
I'll share screen. Hi, Agnes.
I don't know how to use the computer. Try.
That's okay. That's okay. As long as you can do that is fine.
Nice background.
Yeah, that's right.
Yeah, don't step back into the water.
Yeah, that's right. All good. All right. So we should be back into this, the sharing screen now. Yeah, guys. All right. So basically, the things we want to try and talk about tonight is the prevalence of diabetes, what it is, what signs and
No,
symptoms.
no.
Sorry, you okay, Agnes?
Yes.
Yep.
Thank you.
What risk factors, ones that we can change, ones that we can't change, what we should be doing in terms of our normal health checks, talking about some physical eating, healthy eating patterns that we should be adapting to help manage your diabetes, what we can do from an exercise perspective. I know a lot of you guys have either done or are aware of the Beat It program, and then some question time at the end. So we'll aim to try and finish up at about 8 o'clock tonight, but we'll see how we're going throughout. Okay. So,
Sorry, I can't stay the whole time, but I'll get the recording.
yeah, I'll send through the recording through to you there, Karen.
Thank you very much.
And also the presentation through. And then if there's questions, feel free to email me back whenever throughout.
Thanks so much.
All good. So basically, yeah, so diabetes is obviously a really prevalent condition. So we're seeing roughly, I'm just admitting Anne, our practice manager who's joining in, within Australia. So we've got over 1 million people diagnosed in Australia. So it's about 1.3 million. That's people that are actually diagnosed with diabetes, A versions, either type 1 or type 2. Plus, we think there's another 500 to 700,000 that probably are living with diabetes that don't know about it. And so it's about 280 Australians every day are diagnosed with diabetes. So that's one every 5 minutes. So when you work that out, it's about 100,000 people each year are being diagnosed with diabetes. It's growing faster than other chronic diseases such as heart disease and cancer. And a lot of those people, it increases the risk of those other chronic health conditions as well. So they're the things that is currently happening at the moment. The scary thought down the bottom here is that there's about 4,500 amputations per year associated with diabetes. So a lot of people don't manage their diabetes well for a long period of time. And as a result, then there can be severe complications of that. But, if we're talking 4,400, that's roughly 10 to 12 a day that are being exposed to that. So, okay, so what is diabetes? So just throwing it out there, as a general statement, what do people think diabetes is?
Well, it's a metabolic disease where your blood levels are pretty high. It's elevated, and over time it could lead to serious damage of blood vessels, your heart, your eyes, your kidneys, and nerves.
Yep. So when you said blood levels there, Lindsay, what are you talking about? Anything particular?
Well, when the blood glucose and the blood sugar is it's pretty high.
Yep.
In terms of your reading.
Yep.
Then you concerned about that, and you could damage you could damage your body basically.
Sure. Okay. Yeah. So basically, it's just a blanket term for an elevated blood sugar level in the body there. And so it's normally a process of your pancreas either not producing enough insulin, or the insulin that it's producing is not being used effectively from that.
Right.
All right. So, Sal, do you want to talk about what happens normally? So, if you want to go through this and scroll through.
Yeah, sure. So, normally how insulin works is, as I'm sure all know, we have the organ in the body called the pancreas that produces the insulin, and then the insulin. So the job of the insulin is to actually get the glucose into the cells. And so if you think of like your muscle cell, the job of the insulin is basically to unlock the door to allow that insulin into the cell, and so you require the glucose in your cell for energy, help you in your beat it class or going to the gym or going for a walk. So with insulin resistance, basically that cell door becomes harder to open, and the insulin has to work harder to let that glucose into the cells. And this is often happening for a number of years before the actual diabetes diagnosis, in that sort of pre-diabetes stage. So the body keeps on producing, the pancreas wants to produce lots and lots of insulin to get that cell door open, and there's this resistance to allowing that glucose into the cell. And insulin is a very common term that you might find when you look up diabetes. So what are some of our signs and symptoms of diabetes? And does anyone know any of the signs and symptoms of, I think Lindsay's already said your glucose level will be elevated, which is correct, but how might you feel?
Thirsty.
Thirsty, yes.
Yep.
A lot of water.
Yep, because the body's trying to
Maybe.
get glucose, isn't it? Yeah.
Yeah.
There's no wrong answers here, guys, so feel free to contribute in any way. Otherwise, we can just talk, so that's fine.
Yeah. So, yeah, as you said, thirsty and then passing lots of urine. Some people are hungry. You can get blurred vision, and you can often find that the wounds aren't healing as quickly. And so you're more susceptible to an infection. But probably the last one is the most important, in that a lot of people don't get any symptoms at all with type 2 diabetes, and it will be picked up in a routine screening with your GP.
I think that's probably a really common thing that I'll tend to see with patients, like normal patients that we would tend to see in the practice, that they aren't aware that they've actually got diabetes and wouldn't have even crossed their mind to think about it because there is no signs or symptoms. And that's a really common presentation that we'll tend to see, that people aren't aware that they actually have it because there is no signs and symptoms for a lot of people. Or they think that they're thirsty because they're not drinking enough water, or they've got a urinary tract problem for making them go to the bathroom more often than not.
Yeah, I've noticed that, normally they say people that are obese are normally prone to get diabetes, but I was never obese. I mean,
we'll go through that with the risk factors, Lindsay. Yeah. So what are the more common types of diabetes? So type 1 and type 2 diabetes are the most common. There are some other forms of diabetes that we won't talk about tonight, like gestational diabetes and steroid-induced hypoglycemia. But basically, type 1 diabetes usually happens in childhood and early adulthood. And that's an autoimmune disease. And as soon as you're diagnosed, you're dependent on insulin for life. So that's managed with multiple injections, insulin injections, and diet and exercise. But the type of diabetes that probably is the most common is type 2 diabetes. Usually happens we say mature onset, but sadly now in some of our Indigenous population, we are seeing teenagers being diagnosed with type 2 diabetes, but more likely to be in the 40 plus age group. Lifestyle and genetic factors are quite common with type 2 diabetes, as well as insulin resistance. And type 2 diabetes is managed with diet and exercise and medication. And people often say to me, now that I'm on insulin, do I have type 1 diabetes? And the answer is no. You always have type 2 diabetes, but you require insulin to manage your diabetes.
Yeah, so a couple of things on that. I think there's also some people that might be originally diagnosed with type 2, and sometimes as they progress, they can be then transferred into being type 1. I'm not sure how many patients you've seen of that, but we've definitely seen people that have been originally diagnosed as type 2, and then when they've had further tests, they've actually been diagnosed as type 1. But yes, just because you're taking insulin doesn't mean that you're a type 1 diabetic. Right. So obviously the biggest difference is the type 1's an autoimmune condition where your pancreas is really struggling to produce any insulin there.
That's right. Yeah. And look, we do see the odd misdiagnosis of type 1 diabetes, but But predominantly, it's mainly type 2 that we see in the community for that 40 plus age group. I won't spend a lot of time on this slide, but basically it's just showing you what a normal glucose level is. And then as it increases with your fasting glucose to, roughly 5.6 to 6.9 in pre-diabetes. And always remember, that's when your pancreas is really working hard to bring your glucose level back to normal. And then eventually you will have a diagnosis when your fasting blood glucose is 7 or over, 7 millimoles per litre, or if it's 11.1 2 hours after doing a 75 grams of glucose, which probably doesn't happen as much these days with the diagnosis, more with our pregnant ladies. They end up having to take that load of glucose. So often it's on 1 or 2 blood tests. So we can see here that type 2 diabetes is a progressive condition. And so you can see in that impaired glucose tolerance section where your body, your pancreas is trying to produce that extra insulin to bring your glucose levels back to normal. And then at that point where it just can't cope with that anymore and you get that diabetes diagnosis. And then we manage, and it's always lifestyle is the initial way that we manage type 2 diabetes. And depending on the severity of the diabetes, some people will need tablets straight away, and other injectables like GLP-1, which most people will know these days as Ozempic, or there's a few new kids on the block, like Wegovy and Mounjaro. Over time, depends on how early people are diagnosed with their diabetes and their risk factors that they have. So the risk factors we will go through at in a little while. But if you are diagnosed at a younger age with a strong family history, you may require to go on insulin as well as tablets. But a lot of people don't need to go on insulin. So it's a very individual approach. But always lifestyle is no matter whether you're on tablets and insulin, lifestyle is always important from the start right through your diabetes journey. So we look at these risk factors and say, and we've got 2 slides. So our first slide is unchangeable risk factors. So obviously there are some things that we just can't change. We can't change as we get older. So each year we get a little bit older, our pancreas just produces a little bit less insulin. So you'll often see it's quite more common for people in their 70s to be diagnosed with type 2 diabetes because of that age issue. Family history is a really big one. So if you have a strong family history of diabetes, you are a lot more likely to develop type 2 diabetes. And also ethnicity. So if you're from Asian countries, Aboriginal and Torres Strait Island, if you identify as an Aboriginal or Torres Strait Islander, or if you are from countries such as China and India, you are much more likely to develop type 2 diabetes. We've had a past history for the ladies of polycystic ovarian syndrome, PCOS, or a diagnosis of gestational diabetes, which is a diabetes during pregnancy, then your risk of developing type 2 diabetes at a much earlier age is more likely to happen. So they're the things we can't change. But then I suppose what we really want to talk about tonight are the risk factors that are changeable. Now, as Lindsay said, overweight, being obese is a risk factor, but not everyone is overweight that has diabetes. And those people are probably more likely to have that strong family history, or maybe they've had a diagnosis a little bit older in life, or they've had that ethnicity where they're from a country where you're more likely to get type 2 diabetes. If you are carrying a bit of extra weight, particularly in that first 5 or 6 years of diagnosis, it is so important to try and lose a little bit of weight. And there's been some great studies, a very good one in the UK called the DIRECT trial, where they showed that if you could lose up to about 15 kilos within that first 6 years of diagnosis of diabetes, you could actually get your diabetes into regression for a time. So lots of benefits for losing some weight.
Sally, can I just say at this stage I wasn't aware of the OST risk, that assessment tool.
Yes.
I wasn't aware of that assessment tool at all.
Yeah, I think that's a really common thing, Lindsay. Like most people aren't aware of that. You probably find that if it's a GP who's kind of on the ball, or a diabetes educator, but, by the time you'd see someone like Sally or an endocrinologist, obviously you've normally had that diagnosis.
Yeah.
But a GP who's doing quite thorough in their investigation would probably be asking those questions and marking off like a list as what they would be doing, like for risk of any cardiovascular disease there as well. But yes, that OSD risk is something that can be used there to identify their potential risk of developing diabetes. I guess that's really important in that pre-diabetic stage because you're looking at predicting what it's going to be like in 5, 10, 15 years' time. The unfortunate thing that we probably tend to see is that people are much more responsive to then having a diagnosis as compared to going, oh, I might develop this into the future. People are much more responsive once they've gone, oh, I've had this diagnosis. I think I concur with what Sally was saying about if we can get onto your diabetes initially early and you can address that early, your chances of being able to get your sugar levels back into a normal range is significantly higher. Like I probably tend to see, like for the people that I tend to see, it's about 2 to 3 years from when they've been diagnosed. If we can see them in that time, they can make those healthy lifestyle changes, then we'll tend to see people be able to come off their medication. But the medication or their sugar levels being at an appropriate level is much dictated by a diabetes educator, their GP or their endocrinologist. But that would be based on their sugar levels, more on a HbA1c that we'll talk about later from there. Because we've also got to think about that pancreas is producing a lot of insulin. If your sugar levels are naturally high from eating a lot of carbs or having elevated sugar levels, then your pancreas response is to produce more insulin. And when we're younger, we can do that. But the long-term problem there is that the pancreas then can't keep on producing that extra insulin to get your sugars back down to a healthy level. And then sometimes if it's progressed so far, then it's too hard to be able to get them back down, and thus the need for medication or worst case insulin.
That's right. Yeah. Because eventually over time, your pancreas will, it just because it's tried so hard in those early years, in those sort of like pre-diabetes years to produce all that extra insulin, it just starts to wear out and it won't be able to produce as much insulin or very little insulin for some people. So if we look at some of these other risk factors, physical activity, Michael is going to obviously go through that in a lot of detail shortly. Unhealthy diet, and we will go through that in the next few slides. High blood pressure and high cholesterol, super important to discuss these with your GP. We call it this sort of triad of like high glucose levels, high blood cholesterol. When the three of them are all happening at the same time, it really causes some nasty damage. It makes your blood very sticky, and it really can cause some damage to your blood vessels and nerves. So really important to get that blood pressure and cholesterol in the correct range, and that's where your GP will be very helpful. Smoking is very bad for your diabetes. It's not good for the nerves, but obviously it's terribly bad for your lungs and your heart as well. So there are a lot of really great, I Can Quit, which we've got up here, campaigns. So if you are struggling with smoking, I would really suggest having a chat to your GP about some of the techniques that can be used to quit smoking, and whether that's the use of patches. There are all sorts of things to help people to reduce and then to quit smoking. And as we've mentioned a few times, pre-diabetes is a changeable risk factor. So if we look at, and we've sort of talked about this a little bit. So if we look at we think, over a period of time, and we're talking about, years, where if someone has diabetes that's not well managed and they've got these high glucose levels, often that are associated with high blood pressure and cholesterol, and we have this blood that gets very sticky inside our big blood vessels that are for our brain and our heart and also our legs, as well as the smaller blood vessels to things like our eyes, kidneys, and nerves. And if you think about this blood that gets a little bit sticky, this high glucose level, it's going to cause damage to all of those organs in your body. And that may be, for some people, you may not have complications if your diabetes is well managed. But if it's poorly managed, you can end up with all sorts of issues to do with increased risk of having heart attacks and strokes, poor circulation, things like neuropathy where you get nerve damage to your feet. You can get issues like dental issues. You can get sexual function problems like erectile dysfunction for the men where there's nerve damage there, and vaginal dryness for the women. You can get digestive problems like gastroparesis, where you get a delayed emptying from the stomach, skin problems, and as well as obviously diabetes can certainly affect your mental health, so increased risk of things like anxiety and depression. That's sort of the bad news, but the good news is if you manage your diabetes well and you have a good relationship with your GP or your endocrinologist, diabetes educator. Some people go to all three. Some can be very well managed by their GP. It depends how your management is. Then you can significantly reduce the risk of those complications. And I can't stress that enough. That yes, it's a grim picture when you see all the organs that can be damaged, but with really good management, you can significantly reduce the risk. And there's some very good literature out there, evidence-based studies to show that. So what is our ABC or A to F? So a few things, and hopefully if you do have a diagnosis of diabetes and you're listening tonight, you know what your HbA1c is. And this is it's a blood test that your GP will order. And it basically looks back in time. It looks back at the last 3 months because the glucose molecules get attached to the hemoglobin. So it gives you a very good reflection of how your glucose has been over the last 3 months. And you can get a Medicare rebate. You can get it done every 3 months. But, if your HbA1c is stable, it's roughly, twice a year, once or twice a year. So does anyone know what a good HbA1c is? It comes in at a percentage, and it's different to a blood glucose level. Anyone heard of an HbA1c?
Yep.
Okay. We usually say about under 7%, but it does depend on age. But usually if you have a diagnosis of diabetes, we're sort of aiming for approximately 7% or less. People that are older in their 80s may have a slightly higher HbA1c target, but it is usually individualized. But as a rule of thumb, you're looking for your HbA1c to be managed under 7%.
Good. Mine is 6, so it's fine.
Yeah.
Excellent.
Well, Lindsay, you've been doing something like in terms of managing your health pretty well over the last few years, obviously, and even prior to when you're coming here, you're obviously going down at Rebound and exercising there. I think like one of the biggest benefits of doing a HbA1c is it avoids the finger prick test for people to do on a basis, or when they're going to their GP to not have to be in a fasting state there. So the good thing about the HbA1c is it gives you that average over that previous 3 months. So, if you've been consistent over that period of time and managing your diabetes well with exercise and diet and your medication, that's going to show probably more accurately with HbA1c as compared to just having your fasting glucose test once every 3 months or 6 months, because you could have had a week or so or a few days where you've really limited your carbs, thinking, "Oh, I'm going to the doctor," and it gives you a reading that's okay, but that's avoided with the HbA1c test there.
Yeah.
And I think Sally's right there. It's important to differentiate. There's different values associated with the screening that we've done before for the fasting glucose and the HbA1c. Those numbers aren't interchangeable.
And that's right, exactly what Michael said. For some people, you don't actually need to do a finger prick and check your glucose level. So for people that are on no medication or some oral medications, you actually don't need to do finger pricks as long as you're doing your HbA1c. For other people that are on medications where they may, a side effect of that medication may be a low glucose level, then yes, they do need to do some regular glucose checking. But it very much depends on what diabetes medications you're on. Really important to also have some regular dental checks because of your increased risk of dental infections. Eye check is great to do every 1 to 2 years, and you can. If you already wear glasses, you mention to your optometrist that you have diabetes, and they can take a little picture at the back of the eye called the retina, and that's a very good baseline to have, so that if you do develop any eye complications from diabetes, it gets picked up nice and early. So if everything's stable, probably every 2 years is quite adequate for the eye check, and your foot check. Just getting into good habits, checking your feet each day. So if you have diabetes, and it's always good to just check that you haven't got any like little skin tears that aren't healing, or anything under your foot. Like if you trod on something sharp, you always want to make sure that you go to your GP to get that fixed up. I know it's quite a useful thing to go to a podiatrist every now and then, and try and avoid a lot of those home products for, removing corns and things, because they can often burn the skin and they're not good for people with diabetes. And it's good practice to wear shoes inside and out if you have diabetes, because if you do have a little bit of neuropathy where you haven't got as good a feeling in your feet, then the risk is you may step on something sharp or hot, and you may not know about that for a few days. So always good practice to wear some sort of footwear inside and when you go out.
So, yeah, just on, all really good points there. Like, so you might have heard of like your GPs or your educators or your endocrinologists talking about an annual cycle of care. So these are the things that we'll be looking at checking at least on average about once a year. But yeah, that's probably the most common term that we'll tend to refer to, or this ABC. Some people will just prefer the A, B, C, D, E, F because it's the first things letters, and they'll just remember the abbreviations for those. Sorry, Sal. We're going forward.
So medication. So this is such an individualized thing. As I said, some people may need no medications and others may need one or a combination of 2 or 3 diabetes medications. Some people will have diabetes medications and what's called a GLP-1, which is that Ozempic medication. Very, very good for people with diabetes. Not everyone is eligible for it, but you have to have tried other oral tablets first and have an HbA1c over 7% for you to be eligible to get a drug like Ozempic on the PBS. And then other people are on, maybe 3 oral tablets and they also need insulin. And that really just depends on what stage of diabetes you are and how strong effect the diabetes is having on your body. But I suppose the key thing with your diabetes medications is if it's been prescribed by your GP, always go back to your GP quite regularly, at least once a year, probably twice if you're on diabetes medications. That way they can keep an eye on your HbA1c and make sure that the tablets are working. If you do need insulin, there's often a lot of people often feel that they have failed with their diabetes management if they require insulin, and that's not the case at all. It really is just it's what we're doing is we're providing your body with a little top up of insulin, because your pancreas isn't producing enough. And we want to do that because we don't want you developing those complications of diabetes. And this is an issue when people feel pretty good. They don't feel like they have diabetes. They don't feel any different. And they go, why should I take all these tablets and or insulin? Why should I do all of this and check my glucose levels if I'm feeling okay? And this is the hard concept to understand, that we're wanting to give you these medications to get that HbA1c relatively stable, so that you don't develop those complications of diabetes. Anyone have any questions there before we?
Just generally on medications, I guess, is maybe a good thing that if we wanted to ask Sally about. Sorry, Sally.
Yeah.
Like obviously one of the most common medication that we'll see patients taking is metformin. So do people know how metformin works?
Yeah, I'm taking it, and it's a slow release medication which I take at night and helps me during the night, obviously, to to control it.
Yes, very good medication. Helps with insulin resistance.
Yeah.
There's some research now coming out where they're saying, it may even be useful. It doesn't happen really yet, but it may be useful even with pre-diabetes. It's quite a safe medication to have. So that is a very common first-line medication. Sometimes you do need to have it with food if you are new to the medication. And the dose will sort of slowly be escalated. You usually start at a low dose, 500 milligrams.
It does have side effects, and I experienced that. So I was stopped from taking it for a short while, but then the endocrinologist, after he discovered what had happened, he said, "No, you got to go back on it." So, so I'm back on metformin, and thankfully there's no side effects.
That's a good example of you touching base with your medical team, though, Lindsay, to be able to things. So a lot of people will have side effects to medication, and unfortunately, that is a byproduct of taking medication. There are side effects. So keeping in touch with your medical team is obviously really important in that sense. I suppose to talk about from an insulin perspective is that we'll have various types of insulin there. So you'll have a lot of long-acting, slow-release insulin that will kind of have a steady release over the course of the day. And then you might get something that's a lot faster, like Nova Rapid, there, where you might have that with your meals and consuming, where you're having your insulin dose, as well as then having some carbohydrates to match that. But Sally might talk about that going slides. So
yeah, that's right. Right. So we're just going to have a little bit of a chat about diet. Now, you can talk about diet, a healthy diet, for 5 minutes or 5 hours. Obviously, we won't be doing 5 hours tonight. But I suppose I want to acknowledge that there is a lot of probably miscommunication out there. What is a healthy diet? And a lot of people are very passionate about what their diet is the best diet. So I suppose, yes, there are many different ways to have a healthy diet that we can acknowledge. But most of the time, there will be some common themes that come through with whether you are a low-carb person or a vegetarian or you prefer to have a higher protein diet. There are some common themes which I just want to briefly touch on tonight, so that whichever way that you prefer to eat, as long as we have some of those common themes going through, it should be a healthy way of eating. So if we think of when we're building a meal or a plate, there's probably 3 key things that I think we should include with our meals. And we should include fiber, some protein, and some healthy fats. And you say, well, okay, so if we think about some fiber, and there's many different foods, and I think fiber doesn't get quite enough attention as what it should do. We don't, we have a lot of people now that we have like a huge increase of, bowel cancer that's happening in our society. And a lot of that is due to people taking out too much fiber from their diet and adding in some foods that probably don't include enough fiber. So foods that are good for fiber will include things like all our, veggie, lots of vegetables, and we call them non-starchy vegetables, but they're like lower carb vegetables. And there's multiple veggies that are lower carb. And so all our lovely green veggies, broccoli, bok choy, cauliflower, beans, snow peas, bean sprouts, cucumbers, salad, um, capsicum, all those foods, and a lot of them are there. We want you to have at least half your plate with these non-starchy vegetables. Really, really good when you have diabetes, because two things: one, it helps fill you up, and two, it won't have a significant increase in your glucose level. Got lots of vitamins and minerals in it, and it's keeps you regular. So there's a lot of good reasons for adding fiber in your diet. Other foods that have fiber are your healthy carbohydrates. Now, our healthy carbohydrates are things like our potatoes and sweet potatoes, sweet corn, and some grains. So things like some, rolled oats or quinoa or brown rice, barley. So you have some healthy carbohydrates, but you don't have as much of those as you do your non-starchy carbohydrates. So you look at your plate there, it sort of says, a fist size of lower GI carbohydrates. And a fist size is not that much. If we look at what we eat and what we get served when we go out for a meal, let's say we go to an Asian restaurant, we'll get huge amounts of rice, and usually white rice or jasmine rice, which does sadly put our glucose levels up. But it's way bigger serve than what we should be eating, and what all of us should be eating, whether we have diabetes or not. So just think about that, choosing one of those kind of healthier carbohydrates, which can include those foods there. So really go for those like denser, heavier breads, grainy breads, or try some of those grains like a quinoa, or at breakfast time it might be some oats, but you really want to go at least rolled oats or the those steel cut oats. So we've talked about fiber in our in each meal. Then we want to have some protein. Now our protein at the moment, if you look at the guidelines, they say about 0.8 grams per kilogram, but a lot of the studies now are saying we need to have a little bit more protein than that, particularly as we get older. Really important to maintain our muscle mass. If we're eating enough protein to maintain muscle mass, and also, we're coming to see Michael. We want to also preferably gain a little bit of muscle mass as well. So we need to ensure that we're having some protein with each meal. Roughly about 30 grams of protein each meal is a good sort of target to go to. It obviously depends on your weight. If you're a very slight lady, you may need a bit less. If you're a larger man, you may need a bit more. But usually we are trying to add a bit more protein in now than what we used to maybe 5 or 10 years ago.
So yeah, I guess just on that, like the guidelines that I would normally suggest to people if they're looking to try to increase their muscle mass is around 1 to 1.5 grams of protein per kilo of body weight. So if you're an 80-kilo gentleman, you're looking at about 100 to 120 grams of protein over the course of the day. And you also want that split out over the course of the day. So there's some evidence suggests that your body can only consume or break down 30 to 50 grams of protein in a sitting. That excess protein then gets pushed into gets stored as fat. So what that means there is you need to be having some protein over the course of the day. Protein's obviously really effective there, as well as keeping you feeling fuller for longer as well. But yes, if we can increase that muscle mass, that's really important. And that also then helps with increasing your muscle size to be able to get more glucose out of your bloodstream into the muscle.
So what are sources of protein? So you can see there, you want to go with really lean chicken or fish, lean cuts of meat. And I probably wouldn't have red meat more than twice a week because of the risk of bowel cancer. Fish is a great source. So is eggs. If you're more vegetarian based, tofu is an excellent source of protein. Also, your legumes are really good. Legumes have got a little bit of both, so they've got some good quality carbohydrates in them, So they're things like, chickpeas and kidney beans, but they also have some protein in them as well. So they sort of, they cover both those sides of the plate. But you do need a fair quantity of beans to get up to that if you're wanting about 30 grams of protein. So you might have some lentils, with another form of protein as well. But legumes are an excellent source of protein and fiber. So they're the sort of foods we want you to include in your kind of daily meal. And I suppose the ones that we want you to minimize are things like, foods with sugar in them. So, juices, biscuits, cakes, foods that have a lot of hidden sugars in sadly, in things like sweet chili sauce and a lot of those lovely Asian and Indian ready-made sauces, ready-made meals have a lot of hidden sugar. And you go, oh, they don't taste that sweet. But they add all these flavors in to get that sort of really nice. They have a lot of fat and they have a lot of sugar, and it really tastes great. And it's often much higher in sugar than what you realize. So we want to avoid those simple sugars and carbohydrates and white bread and cakes. We want to avoid high salt foods, and we want to avoid those sort of highly processed foods. So things like fast food and we want to avoid high saturated fat meals. So things like anything that's deep fried, fatty meats, fatty chicken. That's not good for our, because we talked about that cholesterol. It's going to increase our cholesterol and really make that insulin resistance much worse. And that's what worries me sometimes with carnivore diets. It's a bit of a thing at the moment. If you follow diets online, it's something that I always have a bit of a look at what's going on. And at the moment, people are going, oh, all you need to do is eat red meat and all your problems will go away. Well, your problems might go away initially, and you might find you've got very good glucose levels, but you added 2 years onto this time, if you're looking at 2027, you'll find that your insulin resistance will get much worse because of this high fat diet. So it's not the protein, it's that saturated fat that we want to really minimize. So lots of good sources of protein. I didn't talk about dairy as well. Yogurt, if you go for a higher protein, lower fat yogurt, it's a really good source of protein when you're looking to add protein at breakfast. There's some good yogurts like Danone and that have added protein in them. If you like cheese and you have a bit of a cholesterol problem, then I would go with a lower fat cheese, and cottage cheese, ricotta, are lower in fat as well. So try to avoid those high sugar, high salt, high fat foods, and then think of that abundance of your veggies. And so it doesn't really matter what you're eating. If you think about, if we look at some of these meals here, it doesn't matter whether it's a stir fry or pasta or, meat and veg. If we think, okay, how are we going to fill ourselves up? We want to have a lot of those non-starchy veggies for our really good for our glucose level and vitamins and minerals, and then just that smaller amount of complex carbohydrate, and that could be the potato or your healthy grain like your quinoa or brown rice, and then you're looking at that nice lean protein. So it's not something that's restrictive when we talk about eating this way. You can eat it in all sorts of different ways, but it's really just adding in those veggies. So if you love pasta, for example, then you might have a smaller amount of pasta, and preferably a higher protein pasta or a wholemeal pasta, if that's okay with you. And then you'll add whatever protein, say if it's a meat sauce, like a bolognese. But to make it healthier, you'll then add in some veggies. So you might grate zucchini in, or but if you go, oh, Sally, that sounds disgusting. I don't want to grate zucchini into my spag bowl. You might have a smaller service spag bowl and have a big salad on the side. So that is a bit of, healthy eating 101. Does anyone have any questions about that before I hand over to Michael?
No, all good, guys. So yeah, a couple of things that I'd only add on there to what Sally's just talked about there. The most common thing that we'll get saying where people we'll ask people what their diet's like, and they'll say, yeah, I eat vegetables, I get some protein, I get some carbs. It's normally the portion sizes that's a problem here. Sally gave a good example about what happens when we go eat out, and those portion sizes are quite full. But that plate model there that's in front of you now is a really good option there of looking at and going, that half your plate of green leafy vegetables. Sometimes people will get the vegetables and think about like the starchy stuff like potatoes, sweet potatoes, corn. They're still good things to have, but they've got a significant amount of carbohydrates in them. They're probably stuff that I was probably brought up there with as a kid of having, okay, these are all vegetables, they're all going to be good, but not all vegetables are the same. So the green leafy vegetables is a big thing. In regards to the processed foods and the sugary foods, obviously they lead to a spike in our sugars really quickly. So then our body's got to produce more insulin to get that sugar back down. So I'd almost think about it as if you're driving a car in the city where it's stop-start, you're going to use a lot more petrol as compared to if you're driving on a highway road and maintaining the same speed. So we want to try and have a mix of the foods that we're having, not just having something that's full of carbs or something that's associated just with all protein or the fat content there is important because if you have a diet that's high in fat, maybe that doesn't have a direct input on your sugars, but it increases significantly the amount of insulin resistance. So it affects the capacity of the insulin to be able to work on those cells, to be able to get the sugar moving from your bloodstream into your muscle cells to be used. So does it directly impact your sugars? No, but it will long-term by increasing your insulin resistance there.
Sorry, Michael, I forgot to mention about fruit.
Oh, yeah, yes, good point. Very good point.
Yeah, so, can you eat fruit when you have diabetes? The answer is yes, but not too much and spaced out during the day. Usually say approximately 2 serves of fruit a day. What's a serve? Just an apple or an orange is 1 serve of fruit. Half a banana is 1 serve. Half of a large banana is 1 serve of fruit. We try to discourage you having, a great big fruit salad and saying, well, that's my serve of fruit for the day, because it does put a little bit of an extra load on your pancreas. So if you can spread it out in between your meals, it's even better. So, you might have an apple at morning tea and an orange at afternoon tea. If you still feel like some fruit when it gets to dinner time, something like some berries would be is a good addition, because you can eat quite a few berries and they don't have as big an impact on your glucose levels. Also, good if you're trying to maintain or lose weight. So if you're desperate for a 3rd serving of fruit, I'd rather you have some berries than eat a chocolate bar or a piece of toast. But roughly 2 serves of fruit a day is absolutely fine. And that can be tricky for some people because they like to graze, but that's a rule of thumb.
Does anyone have any questions on that before we touch on some exercise stuff, guys? No? Good. Lisa, did you want to ask something?
No. I just wanted you guys to refresh my memory regarding pumpkin. Where does pumpkin sit again? Because it's
in the middle, so it's not
okay.
It does have some starch in it, but not as much as potato or sweet potato. So you could like a larger serve of pumpkin as your starchy veggie.
Okay.
If you've just got a very small amount sort of chopped up in a dish, it won't have nearly as big an impact. But it's a very good vegetable. I'd probably just in the starchy, in the potato family, but it's not as starchy as potato or sweet potato.
I guess the only other thing to add on that there is the way you cook it also makes a significant difference. So something like sweet potato or pumpkin, if it's roasted, it goes for that caramelization effect. So then it actually tastes quite sweet, and it's sweet because there's more of the sugar actually coming out in towards it. So if you were to roast a sweet potato or a pumpkin, the nutritional content of it is significantly different if you had boiled or steamed it. So something else to think about just in terms of that preparation of those meals as well.
Or a pumpkin soup.
Well, that's what I'm making tonight. It's on the stove, cooking as we're speaking. So I just thought, I better check.
Pumpkin soup.
Great thing. Yeah, pumpkin soup is great. Yeah.
Yep, definitely a good thing.
Okay. Thank you.
All right. So exercise, guys. What do people think they should be doing exercise-wise? Just generally.
resistance training, a lot of it.
Yep. Why and how much?
Oh. Well, is it 3 hours a week or so much a day? I don't know.
These are good points there, Karen. That's okay. So the general recommendations for exercise with patients with diabetes are quite consistent with what they should be for the general population. So what we're looking at here, so about 2 days a week, 2 to 3 days a week of where we're doing some resistance-based exercises. So they're more looking at our strengthening work. Our aerobic-based exercise, we're looking to do 150 to 300 minutes of aerobic-based exercise over the course of the week. At a moderate intensity, or we could actually half that if we're doing some vigorous intensity exercise. The other important thing to consider is that if I've just been doing my half an hour of some resistance training and then I've done a 30-minute walk, that doesn't give me license to sit down on my bum all day for the rest of the day and do nothing. So we need to try and continue to move throughout the course of the day throughout. So they've sort of guided here 10,000 steps. I'd probably look at about 7 to 8,000 as a guide for most people. Obviously, the more that you've done, the better. So when we're looking at aerobic exercise, so 30 to 60 minutes most days, moderate intensity. So a moderate intensity exercise is something that we might look at going, if you're exercising, could you have a conversation with someone? So sometimes we'll use like a talk sing test. So if you can't maintain a conversation, the exercise is potentially too hard. If it's something where you could sing, then it's probably too easy. So when we're looking at aerobic-based exercise, we're looking at options like there could be walking, it could be swimming, it could be cycling, it could be some step-ups, it could be rowing, any form of exercise that's done continuously. And so, yeah, we do look at 30 to 60 minutes, and ideally that would be done in a 30-minute block. But the evidence around doing 3 10-minute blocks over the course of the day has a similar effect to you doing 30 minutes all in one go. So the common thing that we'll see is that people that have diabetes have other issues related back to their health. So in common things there is knee osteoarthritis, back pain, hip pain, plantar fasciitis, other issues that will limit their capacity to be able to do a 30-minute bout of exercise in one go. So breaking it up over the course of the day is completely feasible. Now, there's also some good information about vigorous intensity exercise and interval-based sessions. So the vigorous exercise, so if we're normally using like a scale of 0 to 10, like 0 being no effort, 10 being maximal effort, a lot of times when we're doing that moderate intensity, we're looking at an effort level of somewhere between 4 to 6. When we're doing vigorous intensity exercise, so this is important because we could almost do half the amount of vigorous exercise to get the similar benefit of moderate-based exercise. We're doing double the amount. So I could do a 30-minute bout of vigorous intensity exercise and get a similar benefit of me walking for an hour. The issue that we see with a lot of patients that have type 2 diabetes, they might have other cardiovascular risk, they might have other health conditions, they're simply not fit enough to actually tolerate higher intensity exercise. So it's a good thing to try to build up to, but it's normally a ratio of about 2 to 1. So if you were to do some interval-based exercise, so you guys that are coming here, you might do like sort of 4 minutes on, 4 minutes off. You will burn up twice the amount of calories in that time. You also have a doubling amount of the increase in your fitness, and you also get a significant benefit in terms of your sugar consumption and your sugar levels. So obviously aerobic exercise can benefit us in terms of increasing your fitness and your cardiovascular fitness. As we're exercising and doing repetitive aerobic-based exercise, those muscles are going to constantly be demanding glucose from your bloodstream. So if we're continuing to exercise, we're going to continually be taking glucose out of our bloodstream, which is going to be useful then for lowering our blood sugar levels. Another really positive benefit out of that is that we'll have increased insulin sensitivity for 24 to 72 hours after that. So in essence, what that means is that we're not going to have to produce as much insulin to get our sugar levels back down for 24 to 72 hours. That's vary, like 24 to 48 hours is probably more accurate, but we see some variance obviously within different populations. The relevance there is that if we're doing something once a week, if we're doing something twice a week in terms of our aerobic exercise, if I do something for an hour on Monday, it's going to have a lasting benefit to say Tuesday, Wednesday, maybe into Thursday. But if I've done something on Monday, I haven't done anything until Friday, I've kind of lost that benefit of that insulin sensitivity. So where this is where it comes in, the idea that we need to be doing it on a regular basis, so 5 to 7 days a week. So, the other benefits in terms of aerobic exercise is that it's going to decrease our blood pressure and our cardiovascular risk, which we know is a really common morbidity associated with diabetes, and also help with our weight management. And so if we can lower down our weight, then we'll get decreased insulin resistance because we won't have so much fat in our body that's going to restrict our capacity to get glucose out of our bloodstream into our muscle cells to go get stored and used. So if we're looking at resistance exercise, so Lindsay, you're touching on this. So we look 2 to 3 times a week. It's kind of seen as being optimal. We're looking at large muscle groups. So we don't necessarily just want to do something where you're lying down, just doing a core-based activation exercise. We want to work on the bigger muscle groups. And that's mainly because if we've got bigger muscle groups that are being used, so the muscles in our thighs, in our buttocks, in our chest, in our shoulders, in our back, if we're working those, if there's a bigger consumption there of bigger muscles that are working, they're going to demand more glucose being moved from the bloodstream into the cells to be used. And so when we're normally looking at doing 2 to 4 sets of somewhere between 8 to 15 repetitions of those exercises. There is benefit of doing higher load and less repetitions. But once again, we're classically seeing a demographic of people that have above the age of 60, have had muscle strains and injuries. They may not have done much exercise prior. They're not appropriate for actually doing those heavier loads. So the 8 to 15 rep range is generally a safer range for people to exercise within. And so obviously our benefits, there's a numerous number of benefits in terms of doing resistance exercise. So we'll get an increase in muscle mass, and then with that, we'll get increased capacity to store more glucose within our muscle cells. We'll get a decrease in our insulin resistance. So once again, we're not having to produce as much insulin. So that's a really good long-term effect because it's meaning your pancreas is not going to have to do as much work to try to get your sugar levels back down. We'll get increased strength, increased balance, and increased fitness, and increased mobility, and people maintaining their independence. It's a really common thing that people will say, oh, I can carry the groceries there, or I can pick up, and we had to move house on the weekend. I could move these boxes before, which I never could do doing that. We get increased bone and joint health. So, commonly as we get older, our bone density decreases by about 2% per year beyond the age of 40. That accelerates quite rapidly in females post and during menopause. So it helps maintain our bone health. So to try to prevent or maintain us getting osteopenia, osteoporosis, and having brittle bones. And it's also generally really good for our joints as well. So if we can get our joints moving under an appropriate load, we can increase the amount of synovial fluid. Those joints can move a bit freer, and you'll get increased range of motion. So that can be helpful in terms of walking, getting around, climbing stairs, whatever else in terms of general movement throughout the course of the day. And once again, the evidence is stating that we're looking at 48 to 72 hours of benefit in terms of that increased insulin sensitivity. So this is where we're looking at 2 to 3 times a week as compared to the aerobic exercise being most days a week, so 5 to 7. The Beat It program. So I'm just looking at time-wise. So we're just on 8 o'clock, so I'll quickly run through this. So a lot of you guys who would have done the Beat It program either in person or online. So I'm scrolling back up again. Sorry, I didn't mean to skip that. So it's basically an NDSS funded program, so a National Diabetes Service Scheme, which the majority of you guys are already members of. Basically, it just involves like an initial assessment to run through your diabetes, your medical history, any injuries that you might have. We have 16 group exercise sessions, so we have up to 8 people in a class, which is done twice a week for 8 weeks. On top of that, we've got some education sessions, so touching on some of the things that we talked about tonight, so goal setting, the pathophysiology of diabetes, what you should be doing exercise-wise, diet, and the effects of exercise on your diabetes. A follow-up assessment at the end of the program to kind of see, okay, what changes that you've made, and then trying to sort out a bit of a plan for you going forward. So we probably tend to see about 30 to 40% of those participants that participate in that beta program continue on in a group exercise plan of some sorts. As part of the NDSS, that program, you're able to do that program once every 2 years. So that's something that's fully funded by the NDSS. So it's been something that we've been running at the practice now since 2019. We were originally doing it at the gym down at North Fitness, where we were originally based prior to COVID. And then we just do it within our practice at the moment here. Following on, like we do get people coming in for exercise groups just afterwards. They run in a similar format from there. On that there, so that funded program through the NDSS is something that people are obviously all eligible for once every 2 years. The other thing that you're eligible for is that once every year, if you have type 2 diabetes, so unfortunately not type 1, you're eligible to get a referral plan from your GP for 8 group exercise physiology sessions as well, which you get a partial rebate back for, and also getting an initial assessment. So you can come in and join in. You could do the beta program for the 8 weeks, and then potentially get one of those Medicare plans and get 8 sessions covered back under Medicare. And then other future sessions could be covered under private health insurance, under group exercise physiology or group physiotherapy. The other part here, so it's a good lead on here into the NDSS. Obviously, most of you guys are already members of the NDSS. Most people become members basically once they. Oh, sorry, guys. I think this. Sorry. It's free to join. It's a lifetime membership. You're registered by your doctor or someone like Sally, a diabetes educator, and they provide a lot of resources, a lot of help and information events and the beta program. So it's something that's funded by the government so that people that are living with diabetes can manage it better. All right. So these are some useful websites here. So back to the NDSS, some programs that they run, New South Wales and ACT diabetes. And this is that Medicare referral form as well. So you can access these as you need to. I guess that's probably the main things that we want to try and run through tonight. If there's any questions going forward, feel free to contact me either via phone or email as is there, and I'll get Sally's contact details. So Sally's mainly working in the endocrinology department at North Shore Hospital, but will also be consulting out of Chatswood and is currently doing it out at Bankstown as well. So whether it's something that you want to go see Sally about in terms of getting some extra information, that's completely great. If you guys want to reach out to me, and I can pass on Sally's details. I guess for maybe the last 5 minutes or so, does anyone have any particular questions that they're wanting to ask either myself or Sally? I know that was probably...
Sorry. I
Yep.
have a question. It's Anna.
Yeah, go ahead.
When we were on the screen about insulin, I just wondered what the indications are about moving to insulin. Obviously, your sugars are out of control and you just can't get tablets to work anymore. But are there any other obvious signs that it's time for insulin?
Yeah, so good question. So basically, when the doctor would think about starting you on insulin would be once sort of there's a lot of other things that have already been looked at. So, that is the lifestyle, obviously, exercise and weight loss if needed. And then those oral medications. And I mentioned before, there can be up to 3 diabetes oral medications that may be prescribed. And often they won't over time. They sort of don't, you need to have a little bit more insulin. Also, that can be included into the mix now, in addition to the tablets, is that weekly injection, which is not insulin, but that's the Ozempic type injection. So all those things are usually tried first, and often you stay on the tablets because they work a little bit differently to insulin. But really, the deciding factor would probably be your HbA1c, that average blood glucose that we talked about. And if that's increasing despite those tablets and all that weekly Ozempic type medication, that's the point where your endocrinologist or GP suggests insulin. So it's an increasing HbA1c that's not responding to those that no longer responds to the tablets.
Great, thank you.
And the reason why we say that is because of those complications. We want to minimise the risk of those complications, and so by administering insulin, that will help minimise those complication risks. So if your HbA1c is suddenly 8%, despite you being on these tablets, your GP or endocrinologist would suggest.
Okay, thank you.
Thanks. That's good to hear.
Yeah, I think just on that, Anna, as well, just because you start taking insulin doesn't necessarily mean you're going to be continuing to take it as well. So I've definitely seen people that have been taking insulin for a period of time. They've been able to act upon that and have a healthy lifestyle change with diet and exercise, and getting weight down is probably the biggest three things there that then they, in consultation with their medical team, they've been able to come off their medication. So it does something that does happen throughout. Yep, Lindsay, I can see you wanting to ask something.
Yeah, I just wanted to add to that. When I was attending Royal North Shore as an outpatient, this goes back years because I've been diagnosed since 1999. And on 2 occasions when the endocrinologist said, "Oh, I'll have to put you on insulin." And I said, well, what do I have to do that I don't go onto insulin? Because I was taking my tablets at the time. She said, lose your waist around the tummy and do more exercise. And that's exactly what I did. And I've never gone on to insulin, thank goodness. And now I'm attending St. Leonards Physio, and that helps me all the way.
Good to know.
5 to 6 years after diagnosis, that really is such an important time to make those big lifestyle changes. The weight loss, the exercise that Michael's been talking about, and if you can do that early on in your diagnosis, you will have a much better outcome, as you have, Lindsay. It's terrific. You've had diabetes then for over 25 years, and you're on metformin. Now, if you hadn't gone down that path, you would probably be on insulin, and it would still be important to take that. But that obviously comes with lots of you have to work a lot harder at you've got to glucose levels frequently and get the timing right with the insulin. So it's a lot that goes with taking insulin. It's an important medication if you need it, but if you can prevent it, then it's obviously it's great to prevent. Yeah.
Yeah.
Maybe
one more question from. Oh, no, I'll give someone else a go.
Yeah, go for it. Unless someone else wants to.
I was just going to ask about CGM, the continuous glucose monitors. They're not available, or they're not subsidised for type 2. Is there any change in the wind on that?
Yeah, good question, Anna. Look, at the moment, no. What a lot of been, I suppose, what is subsidised is people with type 1 diabetes. They are subsidised for CGM. There's a lot of lobbying happening behind the scenes to try and get the government to subsidise people with type 2 diabetes on insulin. So that will be sort of the next group. And then hopefully longer term, everyone with type 2 diabetes could be will be subsidised with CGM. But certainly, in our clinics, at North Shore, we can, if someone is on insulin with type 2 diabetes, we give them a trial, but it is very expensive. It's $100 for 2 weeks for one sensor. So if you are taking insulin, it's a very useful tool to have. If you're not on insulin, look, it's a nice thing to have, but not essential.
Thank you.
One of the things you can really see is when you exercise and you wear a sensor, you can really see the benefits that Michael was talking about of that glucose lowering benefit when you're exercising.
So yeah, so for those guys that don't know, like the CGM is a continuous glucose monitor. So you'd swipe your phone against a little sensor that would be sitting into your arm, and it gets an accurate measure. It's a bit of a delay of about 10 to 15 minutes of your glucose levels. Obviously, the really beneficial thing there is it stops you having to do that pinprick, which people hate doing there. I suppose it's a common thing for some of the people that we will see. They're either taking insulin or sulfonylureas, or people that are just interested to see the effect of their exercise on their diabetes and their sugars levels. Is that normally after a 30 to 60-minute bout of a combined aerobic and resistance-based exercise, people have normally a drop in their sugars of about 1 unit there. So being able to come off the insulin or be able to stay off insulin is definitely beneficial because that hypo risk there is significant. It's something that we want to try and reduce. So if that insulin is going to lower your sugars significantly, and we know that something like exercise is also going to lower your levels significantly, the risk of a hypo there is quite significant there. So being able to stay off insulin for most people isn't appropriate, but obviously it is needed for some people there. If you haven't got good control of your diabetes. All right, guys, it's about 8:15. I've been here a long time today.
Thank you. That was very, very interesting. Very interesting and
I will
beneficial.
send through the slides from today. If anyone's got any questions, feel free to forward them on to me. If anyone wants to get in contact with Sally, I'll pass on her details there as well. So feel free to reach out if there's any questions. There's no silly questions. And then I'll see a few of you guys tomorrow. Lindsay, you're here tomorrow.
I'll see you tomorrow.
Lisa, yeah, all good. All right, guys.
Great.
Thank
Thank you very
Thank
much.
you.
Thank
Bye.
you.
Thank
Bye.
you. Thank you very much.
Bye.
Bye.
Thank you. Thank you, Sally.
Bye. Bye.
Bye.
Bye. Have a good night.
Bye.